Welcome to the Joint Legislative Oversight and Sunset Committee meeting. My name is Senator Kyle Evans-Gay. I represent the 5th District in North Wilmington. I'm chair of the Joint Legislative Oversight and Sunset Committee this year. And as we do every time, and although we are with a familiar group, I would still like to ask the members of the committee to introduce themselves. On my screen first is Representative Yerrick.
Morning, State Representative Lyndon Yerrick, serving the 34th District in Central Kent County.
Thank you, Representative. Representative Spiegelman.
Representative Jeff Spiegelman, serving Northwestern Kent, Southwestern Newcastle.
Thank you, Representative. Senator Richardson.
Senator Bryant Richardson, serving the 21st District from Seaford to Delmore.
Thank you, Senator. Senator Pettyjohn.
Morning, Madam Chair. Senator Brian Pettyjohn, representing the 19th Senatorial District in Sussex County.
Thank you, Senator. Representative Griffith.
Good morning, Krista Griffith. I represent the 12th District, which is in northern Newcastle County. Thank you.
Thank you, Representative. Representative Johnson.
Good morning, everyone. Representative Kendra Johnson, the 5th District, a little bit of a lot of things. Newark, Newcastle, and Bear. Thank you.
Thanks, Representative. Senator Hansen.
Good morning, Senator Stephanie Hansen, the 10th Senate District, which is Middletown, part of Bear, Glasgow, and part of Newark.
Thank you, Senator. And Senator Pinckney.
Thank you, Madam Chair. Good morning, everyone. Senator Marie Pinckney, representing the 13th Senatorial District, parts of Newark, Newcastle, and Bear.
Thank you, Senator. I'd also like our staff to please introduce themselves, starting with Amanda, who is our analyst for the HRB, which is under review today.
Good morning, everyone. I'm Amanda McAtee. I'm one of two analysts for the committee.
Mark's on mute. You knew it was going to happen at some point. Still can't hear you, Mark. I'm so sorry. But that is Mark Brainerd. He is another analyst. I'm going to move on to Holly.
Holly Von Wagner, legislative attorney for the committee.
Thanks, Holly.
Natalie White, administrative support staff for the committee.
And I'm Elliot Graham, the legislative fellow for the committee.
Thank you so much. And I'd just like our Vice Chair, Representative Dorsey Walker, to have an opportunity to introduce herself before we move on.
Good morning. Thank you, Madam Chair. Representative Sherry Dorsey Walker, I represent the 3rd District, and happy to be your co-chair.
Thank you, Representative. Lovely to see you this morning. If we can, our first agenda item is to review the minutes from our April 1st, 2021 meeting, our draft minutes. This was not an April Fool's Day meeting. It was a very productive meeting. We got a lot done. If there are any questions or comments about the draft minutes, I'd entertain a motion to approve them.
Motion to approve, Madam Chair.
I'll second.
Thank you, Representative. Thank you, Senator. All those in favor, please signify with your silence. Anyone opposed, please unmute and say nay. I don't think that was a nay. I think that was just some background noise, but it seems like the motion carries. Minutes are approved. Thank you so much, everyone. And so what we're going to do now is move on to our second agenda item. I'm seeing that we have folks on from DHSS, including our secretary. I thank her for being here this morning. And I believe this would be the right order to take things, but anyone from DHSS can disagree if you'd like to wait, but we're going to get started with the HRB recommendations. What I'd like to do is provide our analyst, Amanda, with a quick minute to provide some updates from the last time that we discussed this entity. But before we do that, I would just quickly like to have our folks representing DHSS introduce themselves. So hopefully we can get right into the conversation and discussion. So Secretary, would you mind starting us off?
Sorry, having audio issues this morning. I was trying to click off, so apologize. Not organized on my birthday. Thank you all so much for allowing me the opportunity to make some comments, and we did submit this in writing for the record. So I want to read it to make sure that we're consistent with what we submitted. Again, thank you all so much for having us here. This is a really important discussion that we're having, and it's a key piece of our strategy around ensuring access, healthcare costs, et cetera. It's not a perfect process. There's always opportunities for improvement. But again, this entity under DHSS has played an important role in our state's healthcare delivery system. So the Department of Health and Social Services and the Delaware Healthcare Commission, again, appreciate the opportunity to provide comment on the role of the Health Resources Board. It was codified in 1978 as an oversight body. The Certificate of Need program was placed within the department. The Health Resources Board in its current iteration was established in 1994 and further modified the Certificate of Need program and replaced it with a Certificate of Public Review in 1999. And as stated in code, the purpose of the Health Resources Board is to foster cost-effective and efficient use of healthcare resources and the availability of and access to high quality and appropriate healthcare services. I'll skip over this part, but as was included in your draft report, the purpose is further detailed. The Certificate of Public Review process, again, plays an integral role in the state of Delaware by providing formal oversight, review, and evaluation of new healthcare facilities, as well as reviewing expanded health services and new or novel major medical equipment. While there may be other review processes for facilities, the Health Resources Board strives to balance concerns around cost, access, and quality specific to healthcare when reviewing applications. This process can also address concerns regarding duplication of services, overutilization of specific healthcare resources, which can result in higher total costs of care without any additional benefits to Delawareans in terms of improving health outcomes. The department recognizes the need and, again, the opportunity to improve and to optimize the Certificate of Public Review process. Since one purpose of HRB is to constructively determine resource needs, the CPR process would benefit from changes that would professionalize the board and the staff and prioritize the use of data for evidence-based decision-making. And this would help us have a more timely, thorough, and informative application process. This new Certificate of Public Review process is also a more efficient and effective mechanism to ensure access, quality, and affordability. The changes will be an overall improvement to the healthcare landscape in the state from where we are now. And if this committee votes to continue Health Resources Board, the department recommends the following to achieve this new and productive CPR process. We recommend evaluating the board size and composition, which may resolve existing deficiencies due to board vacancies. We would ask the consideration for revisiting and revising the statutory language to clarify the definition of quorum. And we would appreciate consideration for updating the application filing costs for capital expenditures. The healthcare and the department, Healthcare Commission and department welcome the opportunity to continue and further discuss these recommendations, as well as other ideas or considerations that the committee has and has already put forward in the 2020 annual report. And obviously happy to address questions.
Thank you, Secretary. Yes, and I think that's going to be, and I appreciate you giving us an overview. We did receive that in writing. That will be a part of the official review packet that will be available to the public as well. So thank you for that. I just want to make sure that we will have an opportunity to ask questions, because of course the threshold question is of course whether we continue or not. So if we can just have, just for efficiency, have the DHSS representatives who are on the call introduce themselves, so that when we do have questions, and we can kind of jump right into them. And then Representative Griffith, I will hop right over to you.
Hi, I'm Stephen Costantino. I'm Director of Healthcare Reform for the Secretary's Office. Thank you for having me.
Thank you, Mr. Constantino. I know we have Dr. Fan as well.
Hi, Dr. Nancy Fan. I'm the current chair of the Healthcare Commission. Thank you for having us today again.
Thank you. And I will note, thank you to Mr. Constantino and Dr. Fan for making time in their busy schedules. I know this was a stretch this morning, and we appreciate the feedback you'll give us this morning. I know that we also have Kiki Evinger from DHSS on as well. Representative Griffith, I'm going to pop over to Amanda, but is there a quick question, or is this more for the discussion following Amanda's update? Okay, we're going to just give Amanda some space real quick and you'll be first. Thank you.
Good morning, all again. I am Amanda, one of the analysts for the committee. Mark's going to share his screen again to put all the recommendations that are on the table. So in light of some recent information, staff made some minor revisions to recommendations 4 and 5. The Office of Health Facilities Licensing and Certification is the process that becomes after HRB was mentioned in the previous meetings. They already collect utilization information, so both offices can work together, and we don't want HRB redoing any work that's already been completed. So those are the minor revisions here, and also in 5, the recommendation to hold over and do progress reporting, which is similar to what we did with DVI and the review from last year. And that's all I have. If there's any questions, thank you.
And Amanda, can you clarify for revised recommendation number 5, was the holdover the change or the progress report timing the change?
Yes, Senator, both. The holdover and initially recommendation 5 was written to release upon legislation, which technically would be a holdover because you would have to run and approve the legislation before the release. So this is rewritten to just explicitly hold over, and HRB submit a progress report in January of 2022, and during the quote unquote off season, they would submit progress report 1 and 2, September and December, and then your staff would prepare a report that would come to the committee when you come back in January.
And I know that recommendation number 2 has not been revised, but can you talk a little bit about how you as analysts would approach recommendation number 2? It seems like there would need to be a lot of back and forth in order to achieve recommendation number 2. Is that correct?
Yeah, that is correct. With most recommendations that are implemented by the committee, we engage the stakeholders, so the agency involved and the other stakeholders that needed to be engaged in the process of implementing anything that the committee adopts as far as recommendations. So we would be engaging DHSS, the Healthcare Commission, HRB staff to facilitate if the committee adopted it.
Thank you. I think we're comfortable unless anyone's having visual issues on their screen, and you can let us know that, I think we're comfortable keeping the recommendations up as we discuss, and so that we can also see everyone speaking, but please let us know if you need us to bring those down. I know that at the last meeting, and not that anyone here forgets, but we do have members of the public watching. At the last meeting, the committee was unable to come to a 7-member consensus on whether this entity should continue or whether it should be sunset. And so I appreciate that in the interim, these revised recommendations have been developed. I also appreciate, though, that at least I had questions, and I think other members of the committee had questions that they felt maybe weren't fully answered or could have had more information at the last meeting. So as part of this discussion, I would like to look towards a potential recommendation, as well as make sure that our committee members receive the information they need to feel comfortable with their vote one way or the other. And so I would like to recognize Representative Griffith, but also would entertain a motion in the near future, if possible, regarding recommendation number 1, with the understanding that robust discussion can occur following a motion. And so, Representative Griffith, the floor is yours.
Thank you very much, Chairwoman Gay. I appreciate it. And good morning and happy birthday, Secretary McGarrick. It's nice to see you and your staff, and kind of you to spend time with us on this important issue. As Senator Gay referenced, at the last meeting, we were unable to come to a 7-vote decision on whether to continue the HRB or to sunset the HRB. I think that was the split. So if you could just, in layman's terms, you or Dr. Fan, explain or advocate or however we want to phrase it, what would happen to the Delaware healthcare system if this organization was sunsetted? What would be the immediate and long-term impact on the delivery of healthcare? I think that it would help to have that information crystallized in my mind in order for me to make my decision on what to do here today. I'm sure you've heard about the discussion that we had, and it was very, I think, as Senator Gay termed, robust. It was engaging, and it's been a good discussion. But I just would like to hear, what from your view and Dr. Phan's view, in terms of just sort of what will be the negative if the HRB was sunsetted? What would be the immediate impact to Delaware and long term? Thank you.
And Secretary McGarrick, just before you answer that, I note for members of the committee, while we are not in a court of law, you unfortunately have a chairwoman who feels more comfortable in a court of law. In the court of law in the state of Delaware, it's expected that nonverbal reactions are held to a minimum. And so if we can keep our reactions through our speech and not through our expressions, that would be helpful and I think most productive for the conversation. Secretary McGarrick, the floor is yours.
Thank you. I will do my best. Unfortunately, I'm not a good poker player because I guess I made a good choice not becoming an attorney. So I think Representative Griffith, it's a great question. And I think this is part of a perennial struggle around how to look at healthcare policy. Because the healthcare system is not like a typical free market system. We're not talking about, do we add another Amazon facility or something else? There's a real lack of, we can go online and say, I want to buy a pair of shoes and what, do I get it here? Do I get it there? You can price compare, you can see quality, you can see reviews, you can see all of these things. That's just not present in the US healthcare system. And so it's really boards and activities such as this that attempt to pull data together to really understand the impact of the decisions. The other way that the healthcare system is not like the free market is that more of whatever we're talking about in the healthcare space does not drive down prices. It's actually shown to increase prices. And I will get you the specific, the person's first name, but there's something called the Romer principle. Gentleman was an economist and basically said that a built bed is a filled bed. There is a lot of incentive within the healthcare system that if you build it, you will fill it. And so absent a board and a process like this that really tries to dig in and look at questions of access, questions around quality, the type of service being provided, whether people have robust charity care standards to ensure that they're not just creaming off the top and saying, well, I'm only going to see healthy, wealthy, well-insured or full cash pay individuals. Absent something like the Health Resources Board, and I do believe it can be modified to address a lot of the concerns that have been raised, we really lose any sort of oversight or ability to have transparency around the decisions. And we just end up with a much more haphazard process where people can put freestanding emergency departments wherever they want, or outpatient surgical centers. And really what that has the impact on is driving up healthcare costs. And so again, people still get through this process. There's still robust discussion. And I think someone could look at decisions and say, I would have gone the other way, but it's a forum and a venue for us to really look at data and have conversations, as opposed to just being at the whims of whoever wants to build wherever they want to build. And then we as Delawareans, whether it's state government or individual Delawareans or businesses, are stuck with the potential fallout, which is increased healthcare costs. And I will stop there and defer to Dr. Phan or Madam Co-Chairs, also Stephen Costantino, because this is a space where he has a lot of expertise, not just work that he's doing with us in Delaware, but previous states.
Thank you, Secretary McGarrick. That helped to answer my question.
Mr. Constantino, did you have something quickly to add that would be responsive?
No, I think, I think the secretary adequately described what I was going to say. I just, I know this is, I just want to say that as I look at these other recommendations, I think the important point to emphasize is that the other recommendations are talking about a change in how HRB operates. And I think that's extremely important because I think those changes are, in my experience in other states, I was actually on one of the CON committees for 3 years. I think these changes make state. I think they actually add kind of a validation and a professionalism of the operation that has been lacking. And so I commend the other recommendations that if you go with those recommendations, you're not keeping HRB the same. And I think that's the important point that I'd like to emphasize. Free market, as the secretary said, it's almost counterintuitive in healthcare. It's not like you have a store, you go look at your competitor, you drop your prices, and you have the ability to choose where you want to shop. Consumers don't even know the prices of healthcare when they get services. It's not like they can shop around. In fact, most of the time, a payer is paying for that, an insurance company, Medicare, Medicaid. So the transparency around that, the free marketplace, is really lacking. I think these recommendations kind of assert a professionalism, potentially a streamlining of the process, and really to make informed decision based on the total healthcare landscape. You know, there's a lot of merges going on in healthcare right now. And just having an unfeathered system where providers can come, you know, even within or from without of the state, coming in, putting services just anywhere. I think Molly talked about the saying that's a bed, but we have a saying that if you create a medical code, it will be utilized. And it won't be utilized with another code going down. They'll both go up. So I just wanted to add that piece. Thank you.
Thank you, Mr. Constantino. And if you're able to add your video when you're speaking, that would be appreciated. So thank you very much for your comments. I think the question, perhaps to add more clarity, I understand what you're saying on, you know, that we can't go and, you know, find a $10 treatment here because it's less than the $20 treatment down the road. But I think what I've heard folks ask or argue is that, you know, if you have more folks in the market, then there's a competition aspect that would provide a value for Delaware citizens. But you know, I've been given information to the contrary. But can you explain that aspect as well?
Yes. So I think, as I said, that these are negotiated price. You know, what you pay in an emergency room. Let's say you had 2 emergency rooms across from each other, right, or near each other. So there's competition, or you have another service. At one point, there were MRIs. In one state, it was the MRI centers were growing everywhere. That never reduced the cost of care. What it actually induced was a lot of utilization of services that necessarily were not required and weren't tied to quality metrics. So we talk about price often, and price is a major piece of the cost, but we don't talk about utilization as much. That, you know, will it increase utilization? 30% of healthcare spending in the country is called waste. Now, by waste, I don't mean fraud. So I don't want to assume that that's right. By waste, I mean inappropriate utilization of services. So competition in and of itself, I think, is an important factor, but simply having unfeathered composition without a process, I think you could have an HRB process that actually enhances or maintains a level of competition that's valid. And I think these changes kind of do that. These suggested changes, recommendations kind of do that. It takes it from the system that you had now, which needs improvement, and makes it a more improved system of reviewing projects based on need, affordability, and quality. So that's it. And that's what I mean, that simply having competition just doesn't drive prices down. It basically just allows another place to bill for the same amount of price, and that's the key component here.
Thank you for explaining that. I'm going to go to Representative Yerrick, who was next in line.
Well, thank you, Madam Chair. Just a couple follow-up points there. One, talking about healthcare, we're trying to make our consumers, healthcare consumers, better consumers, in the sense of the example I like to use most often is that if I have a need to go to the emergency room, and if it's truly a non-emergency, going to the ER versus a doc in a box versus my primary care doctor, there's huge incentives for me as a consumer to use the more practical, more prudent choice of the latter two of those. Two, I would have to question the point about always saying that there's no free market incentives in regard to healthcare deliverables. If I elect to have an outpatient service which isn't covered by insurance, say for example, maybe cosmetic surgery or LASIK surgery, I'm sure going to shop around because I have more of an incentive to find the best value for the price that I'm going to have to pay. You're right, the healthcare system is a broken system where I can flash my Aetna healthcare card and almost have virtually little out-of-pocket expense, but a huge expense back to the state. In regard to somewhat of the point of that, we're just going to have a wild, wild west of healthcare providers coming in here and dropping millions of dollars of money they have to raise just for the sheer sake of trying. I dispute that. One, we're talking about not-for-profit entities in most of the acute care providers, and they have to find a way to raise those resources, be good stewards to their board, to their community, to their stakeholders. I don't think it's going to ever open up some wild, wild west in regard to healthcare deliverables. Let me find a point here that when was the board first developed or started? 1994 for the certificate of need. What was that? 1994, 2000? I can't recall the exact date.
1994, based on the submitted report.
Okay, I'm going to read a release here. State releases first healthcare benchmark trend report for 2019. And I'll quote right from the report. That in late 2018, Governor John Carney signed Executive Order 25, establishing state healthcare spending benchmark, a per annum rate of growth benchmark for healthcare spending and several healthcare quality measures. The first spending benchmark went into effect on January 1st, 2019, and was set at 3.8%, with the target expected to decrease gradually to 3% over the following years. Okay, so you're with me? 2019, we set a goal of 3.8% increase. Now, for calendar year 2019, the report found overall healthcare spending in Delaware totaled $8.2 billion versus $7.6 billion for 2018. The per capita cost increased from $7,814 in 2018 to $8,424 in 2019, or 7.8% increase, more than twice as high as the 3.8% target. Twice, 100% increase. Wow, is the board working, not working? I don't know. But in regard to healthcare spending, when we set a rate of 3.8 and we miss it by 100%, I think the process does need to be reviewed and looked at. And I think with the recommendation number 2, how if we don't sunset the board completely, how the advisory panel is going to help us not miss the mark by 100%. Hopefully we can continue to have that discussion and dialogue. And I'd welcome any feedback from the secretary in regard to what we set as a benchmark, how we missed the mark, and how the Healthcare Commission, the board, was an asset or a detriment to that spending. Thank you.
And for purposes of today's discussion, if you could focus on the latter part, obviously, a quick intro to the first, but focus on the latter part since we are determining what we'll do today with the HRB.
Sure. So I think the healthcare system is very complicated, and there's no, as we see in other states and Delaware, across the country, on the federal level, whichever level you want to talk about, there's no one thing that we can do that will solve all the problems. And it's really important to focus on, I think, as with any endeavor, what outcome are you trying to achieve? And I think with respect to the recommendations and one of the options for the path forward for the Health Resources Board, there absolutely could be an incorporation of the benchmark into as another newer tool in our arsenal around bringing a level of transparency and awareness to healthcare costs. That absolutely could be incorporated into Health Resources Board, and something that those on the board need to again bring into their decision-making process. If you dig into that report at all, and I think germane to this discussion, it's really it's facility based. The cost drivers are in facilities, and so just building more facilities without understanding whether they solve access challenges or they, to your earlier point, they steer people to lower cost of care. It's more the deep end services. It's difficult to imagine how the state has that conversation and where that conversation occurs, if not for an entity like the Health Resources Board, because you could have a for-profit that comes in and just says, I want to plop a hospital down. So your point is well taken, and I would never want to appear to besmirch or call into question the motives of our nonprofit health systems, but they're not the only game in town. We as a state have not had really deep penetration into for-profits coming in, and I would say it's probably because of this process. But absent this process, a for-profit hospital absolutely could come in, and they only have to be, they only have to make the case to their shareholders, and healthcare is pretty lucrative business. It's not hard to imagine, and I don't want to speculate, but I would imagine that they could make a business case that they could make some serious money in Delaware, especially with our senior population in the southern part of the state, by putting up hospitals, freestanding emergency departments, et cetera. So I do want to push back a little bit and just say, I don't think we can just look at it through the lens of the players that we have in the state right now.
Thank you, Secretary. Representative York's hand is down, so I'll move to Representative Spiegelman.
There, that'll work. There we go, mute. So thank you, Madam Chair, and thank you, Madam Secretary. So I have 2 points. One, and they kind of flow together, and I'd like to take a bit of exception. I hate to do this on somebody's birthday. I'd like to take a bit of exception with one of the things you said, and then you repeated it in response to Representative Urick. You can't just put up hospitals wherever you want. That is not true. You can't just put up hospitals. A for-profit can't just come in and just label a piece of land and say, I want to put up a hospital there. There are still checks, and those checks are through local zoning and board decisions, local board decisions and things like that. And so if they, for-profit wanted to put up a facility in Sussex County, and there was the perception that this would help an enormous number of seniors that exist in Sussex County, then the decision should have a lot more to do with those in Sussex County who are making the decision, who have to make that decision because of zoning considerations. So this idea that all of a sudden for-profit hospitals, or anybody for that matter, will just come in and start putting up things wherever they want, it's simply not true. It doesn't work that way. Economic development doesn't work that way, and local zoning doesn't work that way. And something you said, if there is the perception that there is a need for seniors to come in, then I think the residents of that area who are creating the market for that should have more of a say. And this Health Resources Board has proven to be an enormous barrier from a bureaucratic standpoint to do exactly that. So just as an exception, you can't just put up hospitals wherever you want. It just doesn't work that way. And I think that's an important decision as we're going through, that if the members of this board are going to be voting, remove that thought. It doesn't work that way, and it can't work that way. And no business works that way in the state.
And Representative Spiegelman, I'm glad you brought that up, because that was actually one of my follow-up questions from our last meeting. I know you had mentioned the, many other steps, and the question I felt that we didn't get answered from DHSS, and I don't know if anyone's prepared today, but what is the unique piece of those processes that HRB is doing? What is HRB looking at that the planning department would not be looking at.
Sure, and I want to make sure I don't want to take all the questions. Don't want to take all the the heat this morning. I want to make sure Dr. Fan also gets a chance to weigh in, since as the chair, and this is under Healthcare Commission, she probably has some more specifics. But really, I would say that the incentives from an economic development perspective are to build. And I appreciate, again, to go back to a previous, well, let me just say, I appreciate the clarification. I do think it's important to use non-hyperbolic language. So I appreciate the correction. I 100% agree and apologize for being a little loose with the language. People would absolutely have to follow zoning, economic development. I think to make the point more specific and less dramatic, the incentives for economic development and jobs and are very clear cut, and those can be very easily quantified. The piece that, again, is a little bit harder to put a finger on and is not something, I would not call myself an expert by any stretch. So I'm not trying to say like I know and others don't. It's really how this impacts the cost of the healthcare system. So Representative, you're 100% correct that people say, I want this. In the same breath, they go, why are my premiums going up? Why can't I afford healthcare? And what the Health Resources Board attempts to do is to clarify that for people, to just bring another dynamic to the conversation. It doesn't undercut, it doesn't say anybody's doing anything wrong. I completely understand why somebody would say it is, if I can drive 5 minutes versus 20 minutes, of course I want to drive 5 minutes. But if I know that that 5 minutes comes with a cost to the healthcare system and is potentially directly related to why I can't afford my healthcare, that's a different consideration. And again, absent a Health Resources Board and a modified Health Resources Board, I'm not advocating for status quo. I don't know where that conversation happens and how we can help not only educate the public, but the legislature and others who are grappling with these very difficult issues of how do we afford our healthcare system? Where does that conversation take place? How is that brought, again, as a decision point for consideration?
And Representative Spiegelman, you had said there were two things, and I wanted to make sure that you had a chance to say both.
Wrong button, I can't get this right today. No, they were both covered, but I would add to the point, Madam Secretary, in the same breath they say, I want healthcare, is the same breath they say, why are my premiums coming up, are also the same health that say that I have to drive to Jefferson and Philadelphia for a second opinion. And so here comes a hospital that says, no, we're going to do a medical facility here of multiple specialists, where if you want a second opinion from the doctor down the street, you don't have to drive to Jeff, or you don't have to drive to, which I drove to Jeff, or you don't have to drive to U of Penn. I drove to U of Penn in order to get a second opinion, because that was the closest second opinion I could find. I mean, so yeah, we're talking about healthcare costs and that kind of idea, but we're also talking about healthcare choices. And the healthcare choices go with what Representative Urick put so eloquently, which was this doctor this doctor that, and to duplicate the effort it takes to open up a facility like what I'm talking about, to go through the Health Resources Board and its current incarnation. I can imagine getting a call from a national organization or a local one that wanted to expand, saying, Representative or real estate agent Spiegelman, find me a piece of land where I can build this specialty. I've heard that we need it. And then they hear that they have to go through this Health Resources Board. I can imagine, with all the money in my pocket, I could put money on it. Some organization saying, you know what, never mind, we'll go to Maryland.
Dr. Fan, I saw your hand raised. Was there something in addition to Secretary McGarrick's answer that you wish to add?
Thank you. So I think what I want to one of the comments I want to make is that we did mention our statement that we talked about the other review processes. We're talking about facilities here. From the health policy perspective, we look at cost, quality, access, and outcomes. So I feel like we're getting trapped in this conversation about cost. And I understand some of the representatives' comments regarding access is, I think it's notable. I can't say that there's ideal access, frankly, anywhere in this country. And I think then when you start talking about that, what are they accessing? So if we talk about facilities and specifically acute care facilities, increased use of acute care facilities comes at the cost to not just the total healthcare delivery system, but also at the cost of like preventive services that probably have better health outcomes. You have large areas in this country that have a lot of acute care facilities. And I know I used Philadelphia in the past. Philadelphia is a city of over 1 million people. We're a state of 1 million people. They have 5 academic centers and probably 2 to 3 times more hospitals within that geographic area to serve that 1 million people. They have some of the highest emergency room utilizations with not improved health outcomes. So that's one of the things I want to talk about. And also the second thing is yes, I understand the inconvenience of having a second opinion. I refer people every single day to when they don't necessarily want to get their second opinion, frankly, actually in Delaware, to other facilities. But referrals to other facilities as a second opinion doesn't actually improve health outcomes, and it doesn't not improve health outcomes. So saying that having more specialists in a particular area, I'm not sure has any data that actually improves health outcomes, but I think if you are absent an organization that can actually provide that data and that research when they're looking at it, I mean, I think that if we could have one of the lessons learned and improve the process so that it seems more welcoming to people that want to come in when they feel like there's a need, and for us to be able to review that and say, how does this really impact our considerations of costs and outcomes? When you talk about the other review processes, they're not really looking at it with the lens of healthcare. And healthcare, like Secretary McGarrick said, is complicated. It's not just about one thing or another. It's actually about multiple things. And I guess in the end, both as a physician and from the Healthcare Commission side, I guess we want to see, how does this improve the health of our Delawareans? Does it really do that? Now, we talked quite a bit about the total cost of spending here, and we talked quite a bit about, like, you know, how does having acute care facilities drive that cost? Those are very, very meaningful conversations. But in the end, I can't say that you can compare having an organization, not having this organization would actually improve any of that. We think that it's very, very multi-layer about why our total cost of spending is so high. And it's going to take a long time to actually really bring it down to where it is not rampantly overrunning inflation. But we have a tool. It needs to be improved. We all totally agree that. And maybe with an improved tool, we can work towards that. And I guess that's kind of our message here.
Thank you, Dr. Fan. Next on my list is Representative Griffith.
Thank you very much, Chair Gay. You know, these discussions have revealed, and the research that was done on the HRB and the anecdotes that were discussed, you know, have revealed that the HRB is deeply flawed, that there is need for deep overhaul. And but I must say that after all of those discussions, I do go back to what Dr. Fan just said, which is that there exists a tool here in the state of Delaware, and I don't believe, it's my personal view on this, that it's time to give that tool up. So with that, I do recommend and will make a motion that this board go with option 1, which is to continue the HRB. And then I'm going to also, but with my belief that we need to move this from move this to an advisory capacity and follow the other recommendations to really overhaul the HRB. So I move that we continue HRB, which is following recommendation number 1.
Thank you, Representative Griffith. With the motion to adopt recommendation 1, option 1 to continue. Is there a second for that motion? I see Senator, I see some hands and I'll take comment and discussion, but if there's a verbal second, I would appreciate that for ease of.
Second.
Second.
Thank you, Senator Hansen. Is there any further discussion? I know, Senator Hansen, you had your hand raised. Is your discussion related to this, or would you like to hold off?
It would be related to this.
Okay, please, the floor is yours.
Okay, thank you. Well, I've spent a lot of time listening to the conversation, listening very intently to the conversation, and more times than not, I see a lot of this, so many parallels in the land use context that pop up. And being a student and practitioner in the land use process for a few decades at this point, the way that I really see this sort of organizing itself and becoming arranged is to the same way that the planning board exists for the bodies that are making the decisions on whether a large development project actually happens. So, if there are many instances where you have, multi-million dollar development projects, and they're, just as in the decisions for where to locate a healthcare facility, they're going to look at zoning, they're going to do their market studies, they're going to decide, okay, we want to take a chance. They're going to try to cobble together the financial backing to get this done. So it's very similar to what we're talking about here. But before they can get approval to actually get that process, that project done, it actually then goes to a planning board, which is where you bring in the citizen perspective on this particular project. It does add an extra layer of time and cost to the project, but I don't think anyone would advocate getting rid of our planning boards. They serve an incredibly useful and helpful purpose. So that's how I sort of see this organizing in this very in this context, with the HRB becoming like the planning board that we see in regular land use projects. So to me, I see parallels for this in other large portions of our state and county governments. So I'll be supporting this.
Thank you, Senator Hansen. I don't know if the General Assembly ever knew they'd have 2 land use attorneys, in the Senate. So I really appreciate your analogy. Representative Burek for additional discussion on the motion.
Thank you, Madam Chair. Before I would commit to voting for recommendation 1, hopefully we can continue the discussion about recommendation 2, and hypothetically or in reality what the advisory capacity would look like in regard to the HRB. If it's just a matter of a name change, and I'm a no, then I'm going to continue to say I don't think we need the HRB. Yeah, it's a very, very complicated deliverable of healthcare in our United States of America, where consumer choices, my inability to exercise, I smoke too much, I drink too much, I don't manage my type 2 diabetes, individual choices account for probably half, or poor decisions, poor choices account for half the healthcare spending. The ability to litigate over certain procedures that may be done or not done. There's some argument about the cost of what that brings into the healthcare system in regard to preventative medicine or defensive medicine, that I will prescribe that next level of treatment or service just so that hopefully I don't get sued. The Medicaid, Medicare, free care, indigent care, state employee programs where we can add in more and more services onto our plan, but pass the costs on to private insurance. All that being said, yes, it's complicated. But to say that I'm going to be in agreement to keep HRB in existence, hopefully we could, I would welcome the chance to hear more about what recommendation 2 may look like before I commit to recommendation 1. Thank you.
Thank you, Representative. And admittedly, it's a little bit out of order, but so are 3 meetings on one entity. So I think it's a good opportunity for Amanda to share briefly some of the pieces of the report that may be helpful in answering Representative's questions.
Thank you, Senator and Representative. I'm just pulling up the research real quick. So the intent with moving HRB, the idea behind moving it to an advisory capacity is there's a couple things. One, in looking through the long storied history with the board that actually dates further back than 1994. It was actually codified in Delaware. The CON program was codified in 1978. And it was originally with the Bureau of Health Planning and Resources Department. The General Assembly then established it as the HRB that it is today in 1994, and then further modified the CON program and replaced it with the Certificate of Public Review program, which means the same thing, it's just a different name. So that was in 1999. So in looking at the history, because as mentioned, this is the fourth review of the HRB program and its various iterations. There is always in every review, when you look at the previous reviews and the previous reports that this committee has produced on this topic, conflict of interest is always prevalent. So the board size has decreased. It was once at 21 members. So the board membership keeps decreasing. And that is always the thought that that's going to change things. When you look at the conflicts of interest, and especially in the scope of this project, looking at their recent decisions and the often board recusals, the fact that they're not really sure how to handle when they recuse, like how that affects quorum, because it was suggested by them in their questionnaire to define what quorum means in the statute. So you had all those things at play. So really making it advisory puts a state agency at the top as the last measure of making a decision, and it uses the board and the expertise. And of course, this would involve looking at the board structure. If you remember, a year ago, some of our members here today on the committee were present for the presentation meeting from 2019 in March. I'm sorry, 2020. We went back too far. Sorry, 2020 in March. It was suggested, there was some committee discussion about putting a health economist on the board. That representation currently isn't here. So that's one of the things that we would do under recommendation 3 with the statute changes, is look at the board structure. So that goes in part with recommendation 2. When you look at CON laws and board composition across the country, you have 34 states with CON laws. You have 17 that are just done without a board at all. So it's just the agency processing the applications, looking at all the materials and evidence that are collected, and then also aggregating that or comparing it against their own internal, research. So then after that, you have 5 that have advisory boards, such as the one suggested here in recommendation 2. Out of all the states, out of 34, you only have 11 states that have a decision-making board that exists, such as the current model of the HRB board here in Delaware. So and then you also, let me just mention New York, which is close by. They actually have a hybrid board. They have their board makes some decisions on an advisory capacity, and some decisions they make in a decision-making capacity. I also will mention that board has it's a strategic, they have everything, it's really organized, and it's a very robust application process. So that's why they have those 2 things. Also large state, especially with New York City, very high population. So anyway, so back to this recommendation. It exists to solve quite a few problems. One, the major one being the conflict of interest and the transparency. The idea is if you put an agency at the top to make the final decision with the input of an advisory board, that it makes it a more transparent process for the public, and it can, start to dissolve some of that, mistrust or misunderstanding with the public and the conflict of interest, because the board is sitting there to advise. They're also helping to facilitate the public meetings for public comment, applicant comments. They would help with that. But the agency that is over top of the board would be sitting in all those meetings, so they would work together. Also, if you put administrative staff in the decision-making role instead of having the board make the decisions, that also increases the likelihood that they're going to work with other agencies that they need to be more involved with, such as the Office of Licensing and Certification that I mentioned earlier. They really should have a better working relationship to work together. And currently it's it's kind of fragmented because you have a volunteer board that is in control. And that's the other thing. You have a volunteer board. So you have the membership that are volunteer, that are not available and able to do all the research necessary. And then you have an agency that provides some administrative support, but they also have other duties. So really the idea under number 2 would also, really dedicate at least one employee on the agency level to doing the work, which would be the research. And based on all the applications that this board has reviewed, we can see that it's not a very high volume of applications that come in. So it's of our opinion that, at least one state employee could handle that work to better support the board and its role. I hope that answered you.
Thank you. And I would also note too that part of the recommendation number 2 is that any draft legislation formed from the adoption of this recommendation would be presented to this committee, so that I'm sure under the leadership of Representative Dorsey Walker next year, there'll be a robust conversation about whether the draft legislation achieves the goals of the committee in their advisory process, should it go that way. Okay. I know Senator Hansen had spoke. I see your hand, but I'll move to Senator Richardson was next.
Okay, thank you. Thank you, Madam Chair. Since the last vote that we had on recommendation 1, I'm now leaning more towards the open market, free market system. So I probably would have supported Representative Urich's recommendation that we dissolve the HRB. With that said, if we don't dissolve it, I am concerned that we do, go with the first option, that we do take seriously, that we focus really on recommendation 2 and make it advisory. And part of what has been the feedback that I've gotten is I think it's important to look at the activities subject to review, because I think that sometimes that some of the things that are under review by the HRB maybe should be left to the free market instead of going through this process, which just slows things down. And that's the end of my comments. Thank you.
Thank you, Senator Richardson. Representative Dorsey Walker was, oh, I'm sorry, Amanda, we'll just let Representative Dorsey Walker speak, and then we can see if there's any follow-up.
Thank you so much, Madam Chair. My greatest concern is there was a recommendation to add a recommendation brought forth by this committee, and it still hasn't happened. I think that was like 2 years ago, according to Amanda's statement. And then this is, as Amanda stated, that this HRB has decision-making power of the 34 HRBs that exist. And I'm leaning more toward option 2, because as I'm listening to my colleagues, Representative Spiegelman, Representative Urich, this is a process, it's a cumbersome process. And so what assurances do we have that the HRB won't be so cumbersome as we're trying to enhance the healthcare system in our state? Thank you, Madam Chair.
Thank you, Representative Dorsey Walker. And I would see if a member of DHSS is able to respond to the comment or the question.
So this is Dr. Fan. I'll start with a response to that. I appreciate that. I think one of the challenges and deficiencies within the current HRB formulation is that's inefficient, and that's why it's so timely. And I think it's inefficient and quote unquote cumbersome for all the reasons that kind of recommendation 3 actually addresses the board composition, their operational requirements, the quorum, the conflict of interest. So I think making it much more streamlined and effective HRB would also allay some of those concerns about how it's working, and also whether it's going to be in a timely fashion. When you move it to an advisory board, you already have another oversighter saying, hey, look, you got these deadlines. We got to get these answers. We got to have the data research done. We got to be able to have the people come together, and you need to give us an advisory report. That's the way I look at things when I'm talking to an advisory report, regardless if it's in the hospital or if it's on a state organization. So, you know, there is maybe a little bit more layer of guardrails about the operations of the you know, certificate of need process within the state if we're able to move forward with those recommendations. So I do feel that's why, you know, when we've talked about you know, these recommendations, that if recommendation option number 1 moves forward, that we are comfortable with seeing, making sure that recommendation 2, 3, you know, 4, having that utilization review process, having the professionalization of the actual board and our infrastructure and our staff, so that we are able to, you know, check that this information is really appropriate. The information being provided from the application, the facility application, and also what else is going on in the state, for all the other reasons that we've mentioned on the during this previous discussion. So I really do appreciate that's always going to be a concern. You know, we don't, I think that is a, you know, hard lesson learned, that the current iteration of it, you know, obviously has led to all these inefficiencies and regarding moving applications forward, you know. So that is definitely one of the areas that I think not only could be improved on by these recommendations, but probably it would be one of the benefits of moving forward with the other recommendations.
Thank you, Dr. Fan. And you know that I am indeed a fan, no pun intended. I absolutely adore you. So what I'm hearing from you is an assurance that if we go with Representative Griffith recommendation 1, or from you, that recommendation 2 and 3 would be implemented sooner than later, and we won't be back here in 2 years. Is that correct?
I understood that that was the purpose of revised recommendation number 5, because we have these progress reports. But Amanda, am I wrong in my understanding of that?
Amanda.
No, that's correct. The progress reports were put in there because that would allow HR or the staff for HRB to submit a progress report on all the adopted recommendations, you know, 2 of which include major structure overhaul. So that would be in the progress report. Your staff makes the form for that progress reporting. So that's the information that we would be requesting progress on. Obviously, that involves our participation as well, because any adopted recommendation that creates legislation, that's a conversation between our office and theirs. So that would be in the progress reporting sent to the committee. And when I receive those progress reports, Mark and I do send those out. We can send those out to the committee instead of waiting until January, if you would like that.
Thank you, Amanda. Next on my list is Senator Richardson, then Representative Johnson.
I'm sorry, I forgot to lower my hand.
Oh, that's my mistake, Senator. Sorry about that. Representative Johnson.
Awesome, thank you. Here we go. Let me mute everything that is going on. I just wanted to add my thoughts to this conversation. And I'll say, I'm really glad that Senator Richardson didn't have anything else to say, because every time I listen to someone's comments, I'm writing notes here feverishly, and I'm going to run out of space really soon. So just some thoughts that I have, and I'd ask that the committee process this a little bit. I have enjoyed listening to all of the discussion, because it increases my knowledge base, and it just keeps me connected with processes. Okay, I'm very process oriented. So the first thing I will say is that what I know is that there is a need for this entity. There's a need for what they do, right? That's why they exist. The second thing I would add is that we have come to the conclusion that in its current state, it is indeed flawed and inefficient. And Dr. Fan actually said a number of the things that I was writing down here. So we can acknowledge the flaws and its inefficiency. However, we have an opportunity to change the processes and the outcomes of this committee if we indeed adopt Representative Griffith's motion. And in adopting number one, that allows us to ensure that numbers 2 and 3 really happen. And again, I'm going to go back to flawed and inefficient. However, we have the opportunity to help them be successful. These recommendations position the HRB for success, and their success is connected to better outcomes for the customers, for Delawareans. So I felt the need to share that so that we can see the interconnectedness of all things. We say yes to, we know a need exists. We know there are inefficiencies. We have an opportunity to not only make change, but to support them in that change to be more successful. Thank you, Madam Chair, for the opportunity to share my thoughts.
Thank you, Representative. And something that has come to mind to me while we're listening to the conversation too is the idea that it is flawed, and without the ability to move forward in one way or the other, we're stuck with a flawed system. So I'm hopeful this committee can work to find a path forward so that we can have the opportunity to make it a better for the state of Delaware. And I see this. Please go for it.
I'm sorry, this is what happens when you have so many notes down here. The other big thing for me is this, that if we dissolve this and we go towards recommendation, the first recommendation, option 2, if we go to that, what concerns me is this: we lose institutional knowledge. That is of great concern for me and for Delawareans. So thank you.
Thank you so much. Next on my list, and I'm so lucky the list keeps growing today, is Representative Spiegelman, followed by Representative Yerrick.
Thank you, Madam Chair. Representative Johnson, certainly I hear you, Representative Dorsey Walker, and I wonder if, in order to break the stalemate, I wonder if it may behoove us to propose a compromise between these two thoughts. So between Representative Griffith's motion and what Representative Dorsey Walker said, Representative Johnson, yeah, I see it, but I guess what those of us who are here who are thinking about dissolving this are thinking is, where's the hammer? Where's the checks? And I'm not sure that number 5 provides the kind of checks that would make me comfortable in order to break the stalemate. But here would be my proposal. We go with Representative Griffith's option that it shall continue, option 1, but with a 5-year sunset provision. In other words, a sunset provision out at 5 years. That gives the option of renewing the board in perpetuity in 5 years if it's working. If it's not, then the board goes away without much action from this group or the General Assembly at the time. We put sunset provisions on things not all that frequently, but it does happen, especially for ideas and programs where we are unsure if they're going to work or if they've proven in the past that they have not worked and that we're giving them essentially a new lifeline. I wonder if that is a way to break the stalemate. I would vote for option 1 if that was the case, if the motion was modified to include that. I'd be comfortable enough with the motion to do that if there is also a hammer that makes it very, very clear that this committee's intent is, if you don't do what you're supposed to do again, you go bye-bye.
I saw Amanda's hand raised to provide more context likely there for the recommendations. I'll note there's a motion on the table to adopt recommendation 1, option 1, and that's what we're considering right now and having discussion regarding that. Should that fail, there's an opportunity to have another vote. Absolutely. I will just note that I am not in favor of that option. The Sunset Committee is able to bring this entity back, is able to hold the entity over until adequate changes are made. So I believe that function exists already, and I don't believe in setting up an organization to fail. There's no reason for the department to invest in an organization that is slated to sunset in code. And I do believe that we have adequate oversight as evidenced by the fact that we are reviewing this committee again. So I'll let Amanda speak to if you have a response as far as the recommendation, but remember that we have a motion on the table currently.
Thank you, Senator. I was basically going to add that this committee, you know, in recommendation 5, holding this over, you already really have a check and balance in place to kind of oversee this process. And when you come back in January of 2022 and review the progress, the committee doesn't have to release this from review. You can release this from review when you're ready. And, you know, with such huge structural changes, you know, I would say that putting a sunset provision in there for 5 years without re-reviewing it and even looking and evaluating the process, to me would seem problematic. It would be more, I think it would be in better interest if you adopted the recommendation 5 to hold over with the progress reporting. Then you can see as a committee the progress that's happening. If you're not satisfied with the progress in January when you come back, you can certainly state that and go from there. So there's a process here within this own committee to ensure that.
Here, my turn to be on mute. Of course, the recommendations as written are merely the recommendations, and committee members can make a motion to adopt the recommendations as written, and can also suggest revised recommendations. For example, should recommendation 5, should someone request additional oversight or additional feedback or information, that is for the committee to determine. And I appreciate the staff's work to draft those recommendations, even with the caveat that we may not always accept them as written. Representative Yerrick.
Thank you, Madam Chair. And unless something dramatically changes, this will be the last time I speak. I'm wearing out my quota, I can tell.
I don't think the same rules apply, but we'll see.
Well, as we figure out and the bringing healthcare costs and access and deliverables into check, I don't know how many committee members we have, but we're going to go on the road and we're going to be the most highly compensated set of consultants out there. So I look forward to joining my colleagues out there and reinventing the wheel for this. But in all seriousness, that for the recommendation number 1 and what Representative Griffith has proposed, I will support that. However, I'm putting a lot of trust and faith in this into that recommendation 2, that just like my colleague Representative Johnson trusts the process like the 76ers, I think we need to trust the process here and really get back to measuring what matters for that advisory board, advisory capacity, and very specifically what I mean there. I hope that the legislation will bring out very tangible metrics. For example, any entity under XYZ threshold will not have to go in front of a committee. Now we know of the we know of one big opportunity that was missed, the freestanding ER in Sussex County, which we don't know how many other opportunities we never saw presented. But my faith in this board and in the process will be that with the advisory panel that we truly implement metrics and standards and having a set process and timing. Hopefully we can deliver on that, because I think we all agree the competition for healthcare providers is a challenge that is not going to any time soon. As we're getting older, we need more care. We're trying to respond to get increased primary care physicians and internal medicine and acute care facilities. So with the advisory capacity and that legislation goes along with it, I would encourage us to be as specific and detailed into what we expect that criteria to be for what entities have to come in front of that advisory capacity versus what they don't. And again, I look forward to joining everybody out on the road when we start making these huge consulting fees, now that we're going to figure out how to drive down healthcare costs, increase care, and improve efficiencies.
No better way to prepare for that work than the work we're doing now. And I do appreciate your comment about trust. And I think that extends to our staff, that extends to members of the committee and the representatives from the HRB and the department that are here today. Should we move forward, it has to be a collaborative process in that way, and there has to be creative solutions. So I do appreciate you making that note that our work is not done today, should we choose to continue this. Senator Pettyjohn is next, followed by Representative Dorsey Walker.
Thank you, Madam Chair. Part of what I was going to say, I don't have to say anymore since it looks like we're actually going to start moving forward. But my comments relating to the motion that's currently on the floor is simple. We've got a train wreck of an organization right now, and I can't say it any more simplistic than that. There have been very fewer critics of this organization than me. I am very disappointed in what they have done and their performance in the past. That being said, the rules of this committee say we have to have 7 votes to move forward. 7, I've got it right? 7?
You do.
Okay, yeah.
Always.
Yeah. And, doing nothing, failing to get 7 votes to even get through recommendation number 1, I don't think is a good position to be in. We need to make changes to this board. I think everybody here is very clear about the absolute need to make changes to this organization. One of my jobs here in the General Assembly is a whip, and as whip, I count votes. And I don't think we have the votes right now to terminate the board for recommendation 1, option 2. So the next best thing is to go with option 1, and it's clear. Option 1, the Delaware Health Resources Board shall continue subject to any further recommendations that this committee adopts. So I think we need to move forward with option 1. We need to get that off the table so that we can actually go down to the rest of the recommendations and actually recommend some of those substantive changes that we all know has to happen to the board. And going back to what was just said about trust and Representative Urick, trusting this process, trusting the staff that we have here that goes through this, that is going to monitor the Health Resources Board and what they do, monitor the progress of bills that have to be passed by the General Assembly. We can say whatever we want, the 10 members here in this committee, but you still need 11 votes in the Senate. You need 21 votes in the House in order to do anything else. So we need to put forward good changes that will also be acceptable to the majority of the General Assembly to actually be put into Delaware Code so that we can put the proper rails around the Health Resources Board. So last time I was in favor of terminating the board. I think we really need to completely overhaul this board, but to move the ball forward, to move this discussion forward and to implement and recommend some of these recommendations to the General Assembly for the full body to adopt. This time I will be supporting option 1 and I will be voting for that. Thank you.
Thank you, Senator Pettyjohn. Always a good reminder that we're not the final say in all of this, to humble us a bit in our discussion. Representative Dorsey Walker.
Thank you, Madam Chair. I have such an appreciation for the respectful conversation that is always had with the members of the Sunset Committee. And what I really appreciate is each person is open-minded. And I had my mind made up about which way I personally wanted to go as it pertains to the HRB. And Representative Griffith made a motion, followed by Dr. Fan admitting that we do have some issues with the HRB. And hearing from Representative Spiegelman, Representative Urick, Senator Pettyjohn, and I think I mentioned Representative Johnson, as well as yourself, and of course, Amanda, I can support option 1 with the recommendation from number 2 that states will move the HRB from DHSS to the Office of Health Facilities Licensing and Certification. Thank you, Madam Chair.
Thank you, Representative. Is there any further comments or questions regarding the motion on the table to adopt recommendation 1, option 1 to continue the HRB? Okay, seeing none, I would move to a vote, and I think we'll do this as we've been recently, just individually. I'll do a roll call. And so if Amanda, you could please keep track. Thank you very much. And I'm just going to go in the order on my screen. I'm the chair, Senator Gay, voting yes to adopt the motion. Representative Dorsey Walker, our vice chair.
Voting yes.
Representative Yerrick.
Yes.
Representative Spiegelman.
No.
Senator Pettyjohn.
Yes.
Representative Griffith.
Yes.
Representative Johnson.
Yes.
Senator Hansen.
Yes.
Senator Pinckney.
Yes.
Senator Richardson.
Yes.
Thank you to the committee. I believe that was 9 yes, 1 no. And with that, the motion passes. Thank you again to everyone for the robust discussion, and thank you to our friends from DHS for being here. I would ask you that if you stay on the line, we have a little bit more work to do in this regard, and I'll recognize Representative Dorsey Walker.
Thank you, Madam Chair. And with that, I would like to make the recommendation or make a motion that we move HRB from DHSS to the Office of Health Facility Licensing and Certification.
Thank you, Representative. And can I just confirm, are you making a motion to adopt recommendation 2 in its entirety with a change that instead of that to make definite that change, or is this a separate recommendation that you'd like to do it separately?
May I please call upon Amanda to find out what is the best way to make the recommendation?
Great. Yeah, absolutely. Amanda, please share.
Thank you.
Thank you so much for recognizing me again. I would humbly suggest recommendation 2, if you adopted it as written, it already gives your staff the mechanism. I mean, it's our process that we would be talking to DHSS and bringing recommendation 2 to life. And we've already acknowledged that there is a relationship between the two. That I think that would cause for more discussion between our office and DHSS to really figure out the best fit, because there is a great possibility that it's fine where it is. It just needs a lot of restructure and support, as all the conversation has outlined. So I would recommend that that's a little bit premature to make that recommendation to just automatically move them without having all that additional conversation, which would need to exist. And in recommendation 5 to hold over and the reporting, that would be included in the reporting is, some synopsis of discussions on where the best fit is. So I think all that information will come later. Thank you.
Thank you, Amanda. So my question is, and maybe you can help me with this, where it says if we're talking about an overhaul and we're talking about that even the members of the HRB know that something needs to happen, if we keep them where they are, how do they make the necessary transition without the proper supports?
Amanda, if you'd like to answer that, or I can ask a member.
Yeah, thank you, Senator. Real quickly, that's what your staff, we would be doing that. We would be talking to them to make sure that this is going to be a good fit. That'd be part of our process. So, according to our report and these recommendations, we're well aware of the situation, and we would be working in partnership with DHSS to make sure it best fits. So that's in our minds and in our hearts. So that's what we would be doing for you.
Can I follow up quickly, Amanda? Do you believe that any place in your report speaks to the location, or are you saying that you need additional research in order to determine the final location?
Right. We would want to do additional research and conversations with DHSS because, you know, it may be in just a fine place. It just needs more support. Like, and with any agency with, you know, within the state, you know, we always have staffing concerns. So if you're going to move something like HRB to another office, you have to make sure the staff's in place. And we haven't had those conversations in any depth with DHSS to ensure that that would be there. So by just moving it without that conversation and research, we could potentially be moving something to somewhere else that doesn't have the staff and isn't ready to support it. So we would want to make sure before that happens that, you know, all that's in place.
But Amanda, nevertheless, should a member wish to make a motion like that, would you prefer that it be separate, or would it fit separate to recommendation 2?
I would prefer that it be separate, because I think recommendation 2 already speaks to that, you know, that we're already looking at possibly moving it, but it would recall for more discussion, which would be involved in implementing recommendation 2.
And I guess I would just ask as a follow-up to Secretary McGarrick, if you're available, just if there is a commitment from DHSS to evaluate not only the function, but the location of this entity.
Absolutely. We're happy to work with the committee and provide whatever information is necessary to help understand the potential impact of any recommendations and what potentially gaps or, you know, any other information that's needed to help support decisions.
Thank you, Representative Dorsey Walker.
Thank you. So with that in mind, I make the motion that, and happy birthday, Secretary. I make the motion that we adopt recommendation 2 as written.
Second.
Thank you, Representative. Thank you, Senator. Is there any further discussion on recommendation number 2? Seeing none, I'd like to move to a vote, and we'll try it the easy way first and see. All those in favor, please signify by your silence. All those opposed, please unmute and say nay. Are there any abstentions? Hearing none, motion passes and recommendation number 2 is adopted as written. Thank you very much. And we'll move on to recommendation number 3, which specifically references the revisions to the statute and making technical revisions. This is something that we often see with our recommendations from our staff. Are there any questions or concerns, modifications, clarifications for recommendation number 3?
Madam Chair, I move we approve recommendation number 3.
Second.
Thank you, Senator. Thank you, Representative. Is there any questions or comments before we vote? Seeing none, I'd ask everyone in favor of adopting recommendation number 3 to signify with your silence. Anyone opposed, please unmute and say nay. Any abstentions? Okay, thank you. Recommendation number 3 is adopted. We'll move to recommendation number 4. This is a revised recommendation regarding the utilization survey and survey form requirements. Before we have discussion, I'd like our staff just to comment on maybe some of the technical aspects of this revised recommendation. Also acknowledging to our committee members that I know we are against our time. I appreciate your time today. And if you could hold on for a little bit longer, I believe we'd be quite efficient potentially. But please let me know if you need to drop. So Amanda, if you could give a brief update on the utilization survey.
Thank you, Senator. Madam Chair. So yeah, the utilization reports, as mentioned in our recent staff report, they're a huge missing element to this process. And having them do these reports as outlined in recommendation 4, and it's option 1, that actually sets up the research for a later date to, you know, all the conversation earlier about why does this process need to exist. So that actually sets up the information for that review at a later date. And really just the revisions were just outlining the current process with the health licensing and certification office that they already do utilization reports for their applicants. So that is directly in line and correlated to HRB. So they would work together. We don't want HRB to redo anything that's currently being done. So that's the revisions there. Thank you.
Thank you. And just a note for the committee, this is the type of excellent work that comes out of even our delayed process here. We had another opportunity to go back and to make these recommendations even more substantial. So our process has not been for naught. Is there a motion regarding revised recommendation number 4?
Madam Chair, motion that we accept revised recommendation number 4 as written.
Second.
Thank you, Representative. Thank you, Senator, and thank you, Representative Johnson. Is there any questions, concerns regarding recommendation number 4? Additional discussion? All right, seeing none, I'll ask all those in favor of adopting the motion to adopt revised recommendation number 4, signify by your silence. All those opposed, please unmute and say nay. Are there any abstentions? Hearing none, revised recommendation number 4 is adopted. We'll move on to revised recommendation number 5, actually. I'm sorry. Amanda, how do you want me to refer to the numbering there?
I'm sorry, what about the number?
So the utilization survey is revised recommendation number 4. Are we saying that's part 1 and then the next one?
Oh, I'm sorry. I understand now. It's revised recommendation for option 1. It was originally just recommendation for option 1.
Gotcha. Okay. So revised recommendation number 4, option 1 is conducting a statewide healthcare facility utilization and cost study. Amanda, can you explain how this adds to revised recommendation number 4?
Yeah, so this builds on recommendation 4 because recommendation 4 HRB would be collecting this utilization information on an annual basis. Recommendation 4 option 1, the small revision here is making this report after 5 years. So that would be 5 years of data. And then the report would be submitted to the General Assembly and the Division of Research's librarian to be on hand and also put on their website. So that builds on that recommendation 4 in setting up all that research. And then as you can see, the bulleted list, which was in the original recommendation, that's all the information that would be included. So it's also really in line with what the Healthcare Commission is already doing with reporting and kind of just overall looking at the health and everything of, the state of healthcare in the state.
Thank you for the explanation. Are there any questions about the revised recommendation, or is there a motion regarding the revised recommendation? I'm sorry, option 1 to the revised recommendation.
Madam Chair, a motion that we adopt recommendation 4, option 1 as written.
Second.
Thank you, Representative. Thank you, Senator. Any other additional discussion? Okay, hearing none, all those in favor of adopting the motion, please signify by your silence. All those opposed, please unmute and say nay. Are there any abstentions? All right, hearing none, option 1 to revise recommendation number 4 is adopted by the committee. We'll move on to the final revised recommendation number 5, which is the mechanism to release this entity for review. The recommendation here is that this entity will be held over and that there will be 2 progress reports in September and December of this year. I know there were some concerns from the committee regarding follow-up and information. Is there any discussion or requests to modify these revised recommendations? If not, I would entertain a motion to adopt it as written.
So moved.
Second.
Thank you, Senator. Thank you, Representative. Any further discussion? Hearing none, all those in favor of the motion, please signify by your silence. All those opposed, please unmute and say nay. Are there any abstentions? All right, hearing none, that is adopted as well. Revised recommendation number 5. So the committee or the MD will be held over and we'll look forward to the progress reports. We are now 5 minutes over our allotted time. I believe we, or did we, let me just double check. If we had until 11:30, I want to make sure that we're not going to waste our time. So, oh, we did move it to 11:30. So that's on me. I have you all. You can't leave. I psyched you out. And now you're going to work so fast on these next recommendations. So I'm excited to keep moving forward because we do have representatives from DIN here, and they have been incredibly patient, and I'm sure will join us in our consultancy organization that we'll be starting on healthcare in this state now that they're all educated as well. I'm going to turn the floor over to Holly, and she is going to introduce these 3 draft bills. Recall that we've already reviewed draft bills for this organization. These are additional bills. And Holly, the floor is yours.
Thank you. I'm not sure in what order you have these bills. I think we can pretty much talk about them as a collective because they do similar things. So the first bill changes the definition of health insurer to include dental insurers. Dental insurers were specifically excluded from the original governing statute. Now with continued growth and understanding of what should be included in the healthcare claims database, the task force concluded that we should also include dental insurers as mandatory reporting entities. So this bill does that. It looks like it does a lot more than it actually does because I've also reformatted it into a list. So it looks like it's changing a lot more than it does. But essentially what it does is make technical corrections and add dental insurers to the mandatory reporting entities. The other 2 bills, one for the Department of Correction and one for long-term care facilities, do the same thing. They each do the same thing. And that is the Department of Correction bill makes the Department of Correction and any third-party entity that provides healthcare services for those who are in the custody or care of the Department of Correction, they are to sign an agreement with DIN to become an active user of the database, and then an agreement to provide summaries of care for each episode or visit of care. And then the long-term care facility bill does essentially the same thing, says that long-term care facilities in Delaware have to enter into an agreement with DIN to be an active user of the database and share summaries of care for each visit or episode. There are provisions at the end of those 2 bills that would not go in the code but are part of the law that say if you are already existing when this bill is enacted, you have, and this is for both of them, you have 30 days after the date of enactment to sign up with DIN to be an active user, and you have 90 days to start submitting the summaries of care. So we wanted to provide, the bill itself tells new entities what their timelines are. So we needed to have a provision to say, well, what happens if you already exist when these bills are enacted? So I presented that a little differently. Normally I would go 1 bill at a time, just in the interest of time. I thought it might be easier to do an overview. If you have questions that are more towards how this specifically works within DIN, we have 2 people from DIN here to answer those kinds of specific questions, but I'm also here to help with questions about how things are drafted or how the law may impact.
Thank you so much, Holly. And I'll note that Ms. Schiller is here and Mr. Perkins is here from DIN, and welcome them to add additional commentary if needed. I appreciate you being here to answer questions. I think my question would just be, have we talked to representatives of this industry to say that these are reasonable timelines that they could meet? And are we going to work with them to ensure they understand that the bill has passed, if it does pass, so that they're not caught off guard by this change?
If that question was for me, I would ask that Stacy or Scott be asked that. They have been doing much more of the background legwork than I have.
Understood. Thank you.
So thank you, Holly. Thank you, Senator Gay. During the task force process, representatives of long-term care facilities were involved and present at all the meetings, and we have certainly shared drafts with them. DOC, we also notified, and actually we've been speaking with DOC for a number of years about ways in which we can start to get their data into DIN to help improve transitions of care. And so I don't want to speak for DOC, but I believe they in general support this bill. But on the long-term care facility side, what the agreements do is require the contracting to take place within those timeframes. If there are needs to work with them, I'm sorry, not what the agreements do, but what the bills do is require the contracts to take place within the time frame. If there's a need to work with a specific long-term care facility through a technical issue, or DOC for that matter, that will happen. You know, DIN will be able to sort of make sure that that happens on a reasonable time frame and sort of addresses whatever needs are there. And so I believe that they're certainly all aware that this is happening and moving forward, and we haven't received any substantive comments to the drafts.
I appreciate that. Thank you for the update. Are any questions from or comments from committee members? All right, and I think that it would still be beneficial to vote on these bills individually. And of course, these are voting to recommend or release these bills from this committee. Of course, these bills will be discussed and debated in our chamber committees as well prior to any floor votes. Do we want to start, Holly, do you want to start in any particular order?
Just because it's the way I've been thinking about them, perhaps the bill for dental insurers.
We have a
Yes,
motion.
this one that's up. Sorry.
No, thank you. Do we have a motion regarding the bill regarding dental insurers?
I'll make a motion that we accept that legislation as proposed.
Second.
Thank you, Representative Buick. Thank you, Representative Johnson. Any further discussion? All those in favor of the motion, please signify by your silence. Anyone opposed, please unmute and say nay. Are there any abstentions? Okay, thank you. The motion is adopted. That bill will be released. Thank you, Holly.
Sure. Next up is the bill regarding the Department of Correction.
Is there a motion regarding the DOC bill?
I move that we accept the bill as written.
Second.
Thank you, Senator. Thank you, Representative. Any further discussion? All those in favor of the motion, please signify by your silence. All those opposed, please unmute and say nay. Any abstentions? Okay, thank you. That bill will be released.
Thank you. And finally, the bill regarding long-term care facilities.
Is there a motion?
I move that we release the bill as written.
Second.
Thank you, Representative Griffith. Thank you, Representative Dorsey Walker. Any further discussion, questions? Hearing none, all those in favor of the motion, please signify by your silence. All those opposed, please unmute and say nay. Are there any abstentions? Okay, hearing none, motion is adopted and that bill will be released. Thank you very much. All right, and with all that, we still get out technically early, but thank you for everyone for again the excellent discussion and the collegiality and the cooperation and working together to find the best path forward. I truly appreciate you all, and I appreciate the time that the DHSS representatives and the DIN representatives took today. I hope we find continued success as we move through our spring agenda. Our next meeting will be Tuesday, May 4th at 9 a.m. So may the 4th be with you, and you get extra points for costumes. I'm just joking. Thank you so much. If there's no further business, this meeting is adjourned.
Thank you, Madam Chair. And thank you to our superior staff.
Thanks, everyone.